يعني الأول طبعا بشكر الدكتور محمد صبحي for bringing the gym to Cairo. وهو الدكتور أو السيشن دي أنا المفترض my worst case. Actually this is my worst case I have ever met. وإحنا كنا عايزين حالة dissection فإحنا قلنا نشوف حالة فيها 3 dissection وperforation نشوف كل حاجة إحنا عايزينها في الحالة دي. Actually البيشنت ده is my friend. He's a doctor and he is a friend of mine. Dr. HW is a 47 years old patient with no risk factor. He is not diabetic or hypertensive. He is non-smoker. Only he has a positive family history. His father did a cabbage at the age of 53. His lipid profile is an average lipid profile. Total cholesterol is 235. LDL is the average 143. HDL is 34. Triglycerides 197, I'm sorry. He suffers from recurrent typical anginal attacks and his resting ECG is normal. He refused to do any stress modality and no CT coronary angio and decided to go directly to coronary angio. He's a very courageous doctor and he's a friend, and let's see his coronary angio. Here we appreciate that he has an OM lesion and LED lesion. LED mid segment is diseased, mildly calcified, but he's okay, more or less. But here we can appreciate that the RCA has 3 right angles bends. Subtotal RCA at a trifurcation. Okay. So this is a syntax score of the patient. We can go either cabbage or we can do a PCI. It is nearly almost the same, but the patient decided to do a PCI. So we start with the RCA, the critical lesion we see first. And first we go with the regular wire. This is the choice PT2 LS wire. And here we can see that it went into a false lumen. The patient has a chest pain and a sudden movement and everything was out, and then we succeeded to re-engage, and then we have such nasty dissection. It is a spiral one. So I left the wire in the guiding as we see there, and we go with another wire. The other wire was run through floppy wire. I try to navigate this section with this run through wire. Actually, when I saw that I succeeded to pass, actually I was also in the dissection plan. And then I decided to go with this is a Felder XT wire, and then I succeeded to go. But this is what I'm left with. This is a recurrent. Actually, the patient has a severe chest pain at that time. And so what to do? This is what I have. What to do? Any suggestion? What to do now? Any? What?
Before you start putting the jackets somewhere where you don't know where you are, you have a wire there which you're not sure.
But it seems in the direction of the wire that I am in the true lumen. It seems, but I'm not sure that it is in the true lumen. Definitely, I agree, totally agree with you. So, any other choices? Because I have a simple answer for this. Definitely. Hemodynamically stable. Hemodynamically stable, but in severe chest pain. This what? And this is Felder XT. Yeah. Yes. So I am asking. So that's what I'm asking. If you don't have an IVUS, you have So I have a definitely, Eric. This is oh. And I have a simple answer for these patients. Actually, if I have an IVUS, I will do what an IVUS and definitely will be better. But in such cases, and if you don't have an IVUS in the cath lab, I have a simple answer for this kind of complication. This is the answer. We have a deflated balloon, and then we put the shaft of the balloon at the site where we think. And so now we know that we are in the true lumen. We have two branches, and we know where the dissection started. This is actually a very simple trick that I learned when you don't have an IVUS, and then we send to the proximal. What? Definitely, it is another option. But so I will tell you something. The microcast will answer only one question. That let me finish. It will answer if you are in the true lumen or not. But this balloon technique or this tip and trick, this tip will help you to show where the dissection started. So you know that you are in the true lumen or not, and you will know where the dissection starts, and sometimes you have an opinion about the distal part of the artery. So but I will tell you why I did this. Let's go back here. If you look here, I'm sorry. If you see here, I have the opinion that I'm the true lumen. We have a small branch. I have the opinion that I'm the true lumen.
This is the spinal passage.
The section, yes.
No, the wire spinals the artery. So the wire passes this at the lateral side, and then it comes proximally, and then gets out to the true lumen. If you take this again.
Yes.
So the whole body of the wire is outside. You see?
No, actually it is not. So we will see we will see. We will see. Yes.
Because I had a case like that. I took an aspiration unit, which is the same.
Yeah.
I went inside to this element,
But
then I injected the pump.
But you go with aspiration caster, and you are afraid of having dissection. This will be rather different. So, actually, we will see what we finish with. So actually, here, this segment seems that we are in the true lumen because we have two branches. The right ventricular branches appears here. And then I put the first stent. But actually, there's the spiral dissection extends distally. And actually, it seems that the distal end of the wire is in the true lumen because we have branches coming outside. So what we decided that we put another stent. Actually, now we are in good, but this can be considered as good result, but perfection comes at the enemy of the good. So we see that this second stent is not fully deployed, and so we decided to go with a non-compliant balloon for this second thing. Because I feel that you will put the second thing in the subartificial space. So you will then definitely use filtration at that stage. No, no, no. We will see. This is not a true human. So we, this is not a true human? No, the second step. The origin of the origin. Let's see. This is not a true human? I disagree with you. We will see. Let me see. Change the wire. This is wire I spent more than half an hour trying to get there to the distal end. After the second step, no. I wouldn't go for this because actually this is what I have. I don't think this is, I have all the branches distally and I have a good flow. And so we will see what happens. Okay.
Why do you think you didn't get good result with it?
From the...
Why you dilated at a good pressure and abdominal pressure with a good step? And if you are in a true human space,
Yes.
you get a good gut in the absence of calcification.
Yes.
So why do you think the mechanism that you didn't get an adequate expansion of the stem that necessitated you go full dilation in the absence of significant calcification?
I see your point. You are suggesting that I am inflating the stent as a Corte technique in the subintimal. This is what you are suggesting. But actually, doesn't cross my mind, and actually I thought that this is an underinflation of the stent in a heavily calcified vessel, and we will go with, we will see. This is a non-compliant, and so what we have is a catastrophe after this one. We will see. Okay? So we go again in two directions. And actually, this is extension of the dissection. So we go with another stent.
Over the same wire?
Over the same wire, yes. Actually, the distal end of the wire made a perforation at that point, and at that point, we started to stop, and we will see the patient. The patient is hemodynamically stable, and he is pain-free and discharged after 2 days, and after 2 weeks, I did a coronary angio for the patient. We will see. This is his right coronary. The second wire was run through floppy. The wire that passed is the Felder XT wire.
I just mentioned 5 minutes ago that the second wire was a parallel wire at that stage, which is soft tip wire, and let's say BMW wire parallel to this wire to steel distance to RCA. Could give me some confidence because the wire, I guess, was a filter, I guess. So having too much pressure on the tip of the filter wire will go into the inflation, and it gives me more confidence that the second wire goes distant to us.
Actually, with the difficulty I have to pass this Felder XT wire, I didn't have any courage to pull it and then put another wire. And if you were in my shoes in the cast lab, you wouldn't pull this wire for your life. Because this wire, I spent lots of time and have a wire that appears distally in the vessel, and my injection seems that the distal end of the wire, the branches as the distal end of the artery appears well. So I have the artery. Maybe it goes subintimal at a point, but then it returned to the lumen and then again. So even though the wire is in the subintimal, I will end by cart, but I will go finally to the lumen. But pulling the wire and trying again to go with a fresh wire, this will be very hazardous.
I think we present complications that more or less just develop because if you are in an ideal scenario, that is teaching
Yes. So, what? Let's we are. Yes. So, so I want to ask a question. So because there is a debate here. So who is thinking that I was in the true lumen from the start, from the beginning till the end of the artery, and who think that I at a point I was subintimal and then I go to the lumen again and this was a card? So you think what? Yes.
Perforation at the tip of the wire, and it is in the myocardium, so it is, I will neglect this perforation. Because the patient was hemodynamically stable, and we did an echo, and the patient was hemodynamically stable, and 2 days, the patient has faked me and discharged, and this is his final 2 weeks. But you think that the wire was in the true lumen or at a point was subintimal?
I don't think it was a true lumen, but because I didn't have such resistance to pushing a stent in the subintimal area. And you see, I didn't doing any ballooning for the mid segment of the RCA to dilate before getting with the stent. So this is again the scenario of subintimal dissection, of subintimal wiring. So if I was in the subintimal at the mid part of the RCA, the stent wouldn't pass. So let's finish the case. ممكن دقيقة واحدة بس. I have 1 minute. أنا عايز دقيقة واحدة بس to finish the case. During the procedure, the patient hemodynamic was stable, but he was having chest pain firstly. But once I put the first stent, the patient has no chest pain until the end of the procedure. Maybe this is good option after the first stent to have an IVUS for the rest of the RCA. But so انا عايز اكملها وبعد كده نتناقش بس. ادينا دقيقة تانية. لا انا ما دخلت اكشوالي شلنا الايه what actually Yes, definitely I will. Yes, please. Yeah, yeah. 2 weeks later, the patient has no chest pain, as I told you, and discharged after 2 days, and an echo reveals no pericardial effusion or something, hemopericardium. This is his LED, and this is pulsing the wire. I was just imaging the wire while it is pulsed. This is the pre-dilatation of the LED. This is a PVS stance, actually, at that time. This is 2016, and this is a PVS. Okay, so I will pass it rapidly. This is after dilatation of the LED, and this is his LED. This is his OM. Actually, this is my take-home message. Always be prepared for the worst-case scenarios. Perfection is sometimes the enemy of the good. Pay attention to the distal end of the wire, especially if you are using a hydrophilic wire. It is important to know what you can do, but it's more important to know when to stop, and always don't lose your faith in God, in your team, and yourself. Thank you.